Welcome and thank you for joining us today at our final session of the series on the impact of skin color and ethnicity on clinical diagnosis and research. I'm Eric Rubin. I'm a professor at the Harvard T.H. Chan School of Public Health and also the editor-in-chief of the New England Journal of Medicine. I'm also an infectious disease physician at the Brigham and Women's Hospital, which is probably why I got asked to introduce today, because today we're going to cover COVID-19 comorbidities and cutaneous manifestations of systemic diseases in both adults and children. As you know, inequalities in healthcare have been present for many years, but the COVID-19 epidemic has really brought that into relief. We know all sorts of disturbing statistics, that the rate of hospitalization among Black and Hispanic people has been higher than whites, that the rate of death has also been higher in these groups, in particular in adults. And in children, the very frightening manifestation of multisystem inflammatory syndrome, or MIS-C, has also predominantly affected Black and Hispanic children. So today we have a group of experts to help us understand not only COVID-19, but other systemic illnesses. And they're going to help us with both figuring out what skin manifestations are like and how to do the skin exam to try to find those manifestations. So I'm here representing the NEJM group, but I want to thank the Skin of Color Society and VisualDx for their help. In addition, I'd like to thank Zoom Video Communications for their in-kind support for the whole webinar series. And I'd like to introduce our moderator today. Dr. Kimberly Manning is a general internist and a hospitalist, a professor of medicine, and the Associate Vice Chair of Diversity, Equity, and Inclusion in the Department of Medicine at Emory University. She's also the residency program director for the Transitional Year Residency Program. She has numerous academic achievements, and most notable among them are several awards for her teaching. She has a strong passion for building and strengthening diverse clinical learning environments and cultivating psychologically safe learning climates. She's also been on the front line of the COVID pandemic, like many of you who are participating today. So we really welcome her and thank her for moderating this important session.
Thank you so much, Dr. Rubin. I'm so excited, y'all, so pumped to be moderating this really important session. And I want to start with just a little bit of housekeeping notes for us to make sure we're all on the same page here. We definitely will welcome some discussion on these important topics. We've carved out some time for Q&A and hope to get to as many of these questions as we can in the 70 minutes. But please make sure to just add your questions to the Q&A box. We have an awesome team that's helping us moderate those, so we're really excited about those. And also you should know that this session is being recorded and will be shared with all of the registrants. And thank you for taking out the time from your busy midday to register for this great event. I just want to really start off by reflecting with you all for a moment. Y'all know I'm a storyteller, and I like to just think back to, when I was a medical student, when I was in residency, and even since I've been on faculty at Emory, thinking about what my interaction has been like with skin and learning about skin. As a medical student, a med-peds resident, I remember those Kodachromes. I remember my textbooks that had all these images in them. You remember them, the baby with the slapped cheeks. We remember that salmon-colored evanescent rash in the person with Still's disease, that person with a malar rash, right? We remember those images and what they look like. And one thing that I didn't even think about as a medical student at Meharry back in the day was that, none of those images of that skin looked like me. And I did see some skin that looked like me. It was usually captured in venereal diseases. I knew what a chancre looked like on skin of color. I knew what, even some herpetiform lesions looked like as it related to a venereal disease looked like on skin of color. But some of the other things that you see in Skin of Color, they weren't in my textbooks, they weren't on the screens, they weren't anywhere. And so what really happened to me is what happens to a lot of us as learners and as people, right? The things that we see every day, they start to shape how we interact with those problems or those changes in the body and how we think of them. And so as I think about how our interaction with Skin of Color and bias work together, that's really part of why I'm here, not just as a moderator, but as an eager learner, to really try to throw down a speed breaker for myself and fill in some of my knowledge gaps as it relates to Skin of Color, but also to really start to reshape the way that I think about skin in people of color. Let me take that a step further for you and just get you to think with me for a moment. I turn on my TV now, there's direct to consumer advertising where I can see a professional golfer talking about an immune modulator for treatment of psoriasis. And so I start to get these ideas that, coupled with what I saw in class over the years, starts to make me think of skin and conditions of skin as something that really have to be, to treat something like psoriasis or something like that, it might be a luxury for some people and not for others. And this isn't because I believe this, it's just how implicit bias works. And bias is a huge piece of why so many of us have knowledge gaps on simple things when it comes to skin, me especially. I'm not always so sure what hypoxia looks like in darker skin. I'm not so sure what the slap cheek skin would look like, or what does a salmon colored rash look like in someone who has a dark brown complexion. I'm not so sure. And so what I'm really hoping that's going to happen today for myself as a learner and for you as well, is that we will take a step back and really start to think about skin as not just a thing that's in front of us at the very end of the exam, but as a piece that we should really be looking at as a clue, just an objective organ that's right in our face that could tell us so much more about systemic disease, about COVID-19, and about our patients, where they are, what they need. And that skin is not something that is to be dealt with as a privilege, but instead is something that all of our patients need us to both learn about and give our full attention to. I'm so thrilled to start off with our first presenter, Dr. Lynn McKinley Grant. Dr. McKinley Grant is an associate professor of dermatology at the historic Howard University College of Medicine and is the former vice chair of diversity and community engagement in dermatology at Duke University School of Medicine. Dr. McKinley Grant is board certified in dermatology and internal medicine. She's a researcher, a co-author of a textbook on pigmented skin, and she has published articles in peer-reviewed journals, has been a visiting professor and lecturer, and is Albert Schweitzer Fellow for Life. She's currently serving as the president of the Skin of Color Society and is a member of the NMA, National Medical Association, the Academy of Dermatology, the Society of Investigative Dermatology, and the American Dermatology Association. She's also a member of the Women's Dermatology Society and the Inter-Society Task Force of the American Academy of Dermatology. As co-founder of Insight Institute, she develops art and museum-based curricula to improve healthcare providers' diagnostic skills in skin. Dr. McKinley Grant.
Thank you, Dr. Manning. That was a wonderful introduction. And I'm like, how do I find the time to do all of this? Anyway, I'm very pleased to be here. This is everyone has, Dr. Rubin and Dr. Manning have really summarized why we created this webinar series to really address the health disparities. And one of my passions in medicine has always been to be able to recognize erythema and dark skin early on as a way to save lives and improve medical diagnoses. Next slide, please. The event of George Floyd's murder was witnessed. How many of you witnessed that on TV, the video? That was pretty hard for all of us to take. That was one optic of something that we really don't want to see, an optic of social injustice. And then there's another optic that we're going to be looking at today, and that's how the body changes and the skin colors change in all skin types. So the title of this is The Optics of Skin Color, and the changes that happen, and that they are a vital sign in the skin exam. So in George Floyd, we could see, Mr. Floyd, we see his change of color from a brown red to a gray brown, and lips changing in color in terms of the darkness. I like to use our artists. I think they are doing a great job in helping us identify a lot of these changes in the skin, and we'll talk about that a little later. Next slide, please. One thing I want to stress is that in the physical exam, we are talking about skin color. Ethnicity is something that should be self-defined and maybe in the history or how a person defines themselves. But we define skin color as different types of color, and those skin colors occur in type 6 skin. In the upper left corner there is an Indian and an Aborigine Australian. You can see darker skin types in all different types of ethnicities. So race, caste, colorism, and class are not part of the physical exam. So what we will be talking about is the physical exam and how to recognize erythema, pallor, and some fairly severe diseases and purpura in the darker skin types and the melanin-rich skin. Next slide, please. So you want to think about the skin as you see one color, and there's just so many different things that contribute to that color. And one of the main things is the melanin, but that's not the only thing. In the melanin, we see at different levels in the epidermis, and it depends on the size of the melanosomes. The bigger the melanosomes, the more melanin that's present, and the darker the skin. This color of the skin also depends on how much oxygen you have in the blood and how much hemoglobin you have in the blood. Next slide, please. You want to look at the vital signs. Of course, we do that automatically, but we have to go through the skin for every single vital sign. You have to touch for the temperature. You have to look at how a person breathes. You have to listen to the rhonchi. You have to measure the pulse, the blood pressure. And then now we'd use oximeters to do the blood oxygen saturation. Next slide, please. The physical exam is very important, and the life-threatening diseases that you can detect are very important. But one thing that you can learn and do every single day with every patient is learn what normal skin looks like. So when something abnormal comes along, you're able to recognize it. You're able to recognize pallor. Pallor also, every mother can recognize pallor or paleness in their child. So we want to be able to, and that's a very serious sign, as we saw with Mr. Floyd. So we want to be able to recognize that. So seeing as much normal skin as you can really will contribute to that. And to recognize what anatomical bulges, cavities, atrophy of the skin exist normally are important. So if an abnormal one pops up, you recognize it. Next slide, please. You want to use your 6 senses, okay? You have the vision and location. Location is so important in dermatology. You can get a big jump on your physical exam if you just think about what things occur in certain locations. You want to look at the color, the pattern, and as I say, the topography. And that means the surface, so flaking, blisters, see if you can divine the surface. So you've got to touch the skin. You've got to, you can actually use your olfactory senses to detect Pseudomonas or other bacterial infections. You don't have to use taste. We don't need that. And then your 6th sense, of course, and hearing. You definitely need to be able to hear the sound even of dry skin, the rubbing of the dry skin. And your 6th sense is very important to develop, and with empathy, intuition, and combining your experience with your thoughts. We have several tools in dermatology that we use, but these are tools that you use in all of medicine to perform a physical exam. And of course, light is the most important, and natural light is wonderful to really be able to find the borders of things and to detect erythema in dark skin. We also are using oximeter, which is a form of light use too, to measure the blood the O2 saturation. We use glass slides to detect whether someone has purpura, whether there's blanching or not. Cameras can be used so you can do telehealth, and tape measure is always helpful to measure a lesion. Next slide, please. So we have a lot of optical illusions in medicine. Don't forget that, remember that the sky's not blue. It's that we see blue first when we look up at the sky. And blood's not blue, blood is red. But when you look at it through the skin, because of the Tyndall effect, you see blue veins. So keep that in mind when you're looking at skin, and the skin colors are different. You want to look at the different layers. Next slide, please. So we have Fitzpatrick skin types that we use. The only problem with that is that they're related to whether the skin burns or not. And we know that all skin burns. So type 1 may burn more easily, but type 6 skin definitely burns, and definitely burns when you have blood pressure medicines that are causing it to get a photodermatitis. Next slide, please. There are artists, as I said, I call on them for big help. And Byron Kim has been absolutely amazing. He does portraits of the skin, and he mixes paints, sometimes up to 14 different colors, to get the exact skin type. His theory, though, is, and our next project is really to look at why these skin colors are not portrayed well in the digital world, because we're going to have that problem as we learn more of our medicine by digital, and with these kind of webinars, we're going to be learning that maybe it's not the same exact color as when you see the live patient. So I want you to keep that in mind as you attend more of these webinars too. Next slide, please. And there's another artist who has used Pantone to match up photographs, and her reference is in the chat. Next slide, please. So one of the things that you see here are two patients, and they're both have bacterial sepsis. If you look at the ear in the patient on the right, on my right, it is definitely pale. So that's a pallor, and you want to go further up to look at the normal skin, and it's a little browner, and you see the border of the erythema going around, and it's sort of a triangular shape, and it's getting darker as it comes towards the center of the lesion. But the subtle red is very important to recognize in all lesions. But you can also, the pallor, his crit's probably very low, and he is intubated, and he's pretty sick patient. Purpura of the toes, we are seeing that more with COVID, but this is a pernio. This was taken many years ago, and this is from bacterial sepsis. Next slide, please. Calciphylaxis in our renal failure patients. Unfortunately, you've got a chance to see some of these slides already if you tuned in early, but it's very important. In people of color, often the lesions of calciphylaxis, let's say they're even renal failure patients, they will, someone might assume that they are drug users. They're, these are ulcers from drugs. Hopefully that doesn't happen, but we have seen misconceptions of ulcers, and this has to be detected. The erythema has to be noted, and the purpuric lesions have to, and this has to be realized. This is more of a hemorrhagic crust. This isn't just an ordinary scab. Next slide, please. Implicit bias exists actually in medicine when you're diagnosing diseases, as we know. So you have seen calciphylaxis, and the next slide you see is another ulcer. But this happens to be an elevated lesion with an ulceration, and it's completely different. It's a melanoma, metastatic melanoma, which we all hear, well, Black people don't get skin cancer, but we do get melanomas and die at a higher rate from melanoma. So you must recognize the biases you get just from the diseases that you learn about, so that you don't miss things like this. And I'm trying to show you, next slide, please, diseases where a biopsy would really help you. Erythroderma is another one of the more serious conditions, and you really have to come up with a good differential diagnosis so that you can treat. You have to look for every clue. In this patient, he's got excoriations in the upper back. He is clearing somewhat of the middle back, but there's significant weight loss with the abdominal, the back folds there, the skin just sort of hanging there. And then you look at his face and he's got temporal wasting. The redness is purple. It's a deep, dark brown purple. He is erythrodermic. And a lot of you want to use the word erythematous. You've got to know what skin type you're talking about. This is a type 6 skin with erythema. But your differential diagnosis is very significant. Psoriasis, lymphoma, drug reactions, atopic dermatitis, malignancy, all of these things you have to be able to diagnose and have a direction for diagnosis. Next slide, please. We all learned in medical school, anemia, the first place to look is the conjunctiva. Do that if you're not comfortable in other ways, but just take a look. Those just some clues of where you can find those signs. Next slide, please. You're going to be seeing the COVID patients come in with comorbidities. Many of you know that, diabetes is a comorbid sign, but we see acanthosis nigricans just in plain obesity also. But take these things as a clue to guide you in right directions. This patient, may be more ready to get the vaccine, because they have a comorbidity, or it might get antibodies once they're available. Next slide, please. This is a very crucial area to recognize the redness. If someone comes in and they're swollen lips, but it's, the parents are saying they're swollen. Angioedema is very serious because the airways may be affected also. Next slide, please. I want you to just pay attention to the hand. I want you to see the change from the palm to the wrist of the erythema that's going up the hand. So it turns into more of a brown. Very subtle, but it's extending. Next slide, please. This meningococcemia, this is a very severe late case of meningococcemia. We want you to recognize the purple lesions before you get to this point, but very important to just start the antibiotics running if the patient happens to come in at this late stage. Next slide, please. This slide I love, and you'll hear more about atopic dermatitis, and this is clearly different patterns that you're seeing. So psoriasis, I want you to see the color that I see, okay? It's a pinkish, or it can be more purple in dark skin. It's very symmetrical. Then you go to the next slide, that's lupus, and it is, a deeper purple color, indicating that, more of a systemic involvement. And then you go to atopic dermatitis, which is lichenified with this crisscross and very itchy, and more of a deeper purple color with a different scale. Next slide, please. Drug reactions are crucial that you're able to identify them. The dress, and you've seen this earlier, will start on the head, and then you have this fine maculopapular rash. All of that is erythema, that's an erythematous base. You have your photodermatitis, which is very dark in a darker person, but you can see by the distribution, location, location, location. You get to Stevens-Johnson, which you see more frequently in all specialties, and you wonder, which is the normal skin? Well, ask the patient. The skin that's normal in this case is the lighter brown skin. The darker skin is not the abnormal. That's where the blisters are occurring. Next slide, please. Lymphomas, these are not cysts in the scalp, or the patient comes in with a growth. These are, if you touch it, it's rock hard. So pay attention to this. Very serious things can look like just a cyst that's coming in, or something that is maybe even infectious in this case. So you really want to take a biopsy. Next slide, please. Again, look at your normal skin. We see a lot of measles. It's, a viral exanthem. You want to look for other signs, but again, see the normal skin. Next slide, please. So takeaway points. look for the normal skin first and the rash. Talk to your patient, ask them to help you. All of the patients I've seen, I've learned so much from over 30 years. Learn from your patients, get a photograph. What did it look like before? Touch the patient, see if there are any changes. Look closely and really try to define the pattern. Is it diffuse, localized? Where is it occurring? Look at nails, conjunctiva, hair, all will give you clues. You're really looking for things that you can detect early. And when evaluating for COVID, you can look for the signs of comorbidity. Even through all of your PPEs, you can look, you can move the patient, sometimes with great difficulty, but take a look and see. Next slide, please. So is the skin a vital sign of life, health, and disease? I say yes. And skin colors and ethnicity really matter, and it impacts the clinical diagnosis. It impacts the research information that we need to get, from our medical records, and it will reduce the health disparities that are experienced if you learn to recognize erythema, purpura, and any skin changes in the skin that could be life-threatening or that are related to systemic diseases. Thank you very much, and we really appreciate all of the sponsors, co-sponsors. It's been great working with everyone, and just for being here. Thank you.
Thank you so much, Dr. McKinley Grant. That was amazing. And providing us with that great background is so critically important as we move forward and care for our patients with COVID. Furthermore, as we think about PPE as a barrier for us to really get in there and look at our patients, especially when they're so sick and having lung issues and so much more, it's a real challenge. I do have a question for you, but in the interest of time, we'll definitely need to move on to our next presenter, and hopefully we can get to some more of those questions at the end. Our next speaker is Dr. Candace Heath. And Dr. Heath is board certified in dermatology, pediatrics, and pediatric dermatology. And she enjoys providing care to your whole family from newborn to 115 years of age. Dr. Heath currently serves as an assistant professor of dermatology at the Lewis Katz School of Medicine at Temple University in Philadelphia. Dr. Heath has been involved in dermatological clinical research, has published several scientific journal articles, and a textbook. She is a fellow of the American Academy of Dermatology and the American Academy of Pediatrics. She's a member of the National Medical Association, the Society for Pediatric Dermatology, the Pediatric Dermatology Research Alliance, and the Association of Professors of Dermatology. Dr. Heath.
Thank you so much for that amazing introduction. I would like to make one correction. I have not published a textbook, but if there are any editors out there looking for someone, then hey, give me a holler. But I have published multiple chapters in textbooks related to skin of color.
And you got the red dress memo, so we're good.
All right, thank you so much for having me. So we'll go ahead and dive right into COVID-19 pediatric manifestations and a call to eliminate dermatology disparities. Before we even start, I would like to say thank you to all frontline healthcare workers, whether you are doing something that you feel is small, whether you feel like there's something that you're doing big, everyone counts, and we thank you for your service. As you may have noticed, when you go into the hospital, all members of the House of Medicine are present and helping in this pandemic. This is a picture of me. I actually served as a frontline worker, taking care of medicine patients during the height of the COVID pandemic to help out my colleagues who were really swamped. So just having an extra pair of hands, if you're able to do it, I encourage you to serve in this way. So the COVID-19 guidance that has really been projected has really heavily focused on adults. So I'm really grateful today that I have an opportunity to share with you some skin manifestations of COVID-19 in pediatric patients. COVID toes probably are the most common thing that you have heard about. And I definitely want to thank Dr. Lisa Arkin for this beautiful photo of a pediatric patient with COVID toes. And most of the kids who have this are young, they're healthy. It can happen not only on the feet, but you can also get involvement of the hands as well. They are typically well and asymptomatic. And if you were to swab these patients, they're often negative. Also, you may see pediatric erythema multiforme-like lesions. On the left is a reference photo that shows what erythema multiforme looks like. And in the setting of COVID-19, it's going to look the exact same. The patients are typically asymptomatic, or they may have very mild symptoms. So remember, in pediatric patients, yes, they can have respiratory symptoms, but gastrointestinal issues like diarrhea definitely do predominate. These are some pictures of pediatric urticaria. So I'm testing you on what Dr. Lynn McKinley Grant already showed you. Can you recognize the erythema in these patients? It is important. So these are some examples of what urticaria would look like. And in the setting of COVID-19, it would look the exact same. The patients are typically asymptomatic. And usually in these cases, there is someone at home who is COVID positive or may be suspected of having COVID. And as I'm going through the slides, you can definitely check out the chat. There were some amazing authors who have published multiple times on COVID in pediatric patients. So I definitely wanted to highlight that information for you. So the next manifestation that can happen are vesicular eruptions. So if you take care of a lot of children or you're caring for a lot of kids, yes, there are other things that are more common, like this Kodachrome of a child with herpes simplex virus. But in the setting of a pandemic, if a child has a vesicular lesion, we also need to think about COVID. There are also some other findings in COVID-19 that have been reported in children. This is a photo that was given, was lent to me for this presentation by Dr. Erin Mathis. And I want to thank her for actually allowing us to use this photo. This is one of her patients with a vasculopathic rash. So you can see the net-like livido pattern on the patient's legs. For my colleagues who are in other areas of the country, you can even see a dengue-like exanthem that you would recognize, but actually it could be COVID-19. Pityriasis rosea-like lesions in children have been reported, viral exanthem-like lesions, and even some minor mucosal involvement as well. So let's start to talk about the most dangerous manifestation of COVID-19 in children. And around the world, colleagues have described it very similarly. However, there are few names for this condition floating around. Some publications may list it as a Kawasaki disease-like inflammatory syndrome, or a pediatric inflammatory multisystem syndrome, or a multisystem inflammatory syndrome in children. All of it today, I'm going to lump all together, and we're talking about it as a whole. So, in comparison to Kawasaki disease, when you have a patient who has MIS-C, this is what you may see. You may have a patient presenting with GI distress like diarrhea. Also, they may be more likely to have myocarditis than your standard Kawasaki disease patients. And they also are going to have shock syndrome. This first photo that we're looking at was provided by Dr. Sharon Glick for this presentation. So I want to thank her for providing this photo and the one on the next slide. This is the second photo that she provided, and it really gives a nice example of desquamation that can happen in the perineum area in a child with skin of color. You really have to look close and know it's not just hyperpigmentation, it's actually desquamation of the skin. You can also have polymorphic rashes, you can have erythema of the feet, and a non-exudative conjunctivitis. So let's switch gears and talk about some comorbidities and statistics in pediatric COVID. So here in the US, African American children are at higher risk for COVID-19 in comparison to other ethnicities. And they also have a higher risk of requiring hospitalization. And overall, most of the severe cases here in the US occur in African American children. So we know that research shows that a lot of African American children here in the US have highest rates of asthma. However, in the setting of COVID, there has not been an association found between COVID-19 infection rates and also asthma. Has not been found. The link has not been found. So if we think about the comorbidities related to this condition and try to explain, how is it that this group out of all groups is having such severe cases, it may have something to do with health disparities. So I'll give you an example. There could be a lack of access to healthcare. That could lead to a delay in actually seeking medical care. That means that you have more time to walk around and to be in the home and infect other people. And then we think about housing, even patients who actually live in homes versus in crowded situations, that crowded situation can actually make them more at risk of exposure. And economically, when you look at the rates of home ownership, the patients who are being the most affected by COVID and dying from COVID have the lowest rate of home ownership. So we need people on the front lines. We talked about being on the front lines of the COVID-19 pandemic. But now I want to challenge you to think about being on the front line to end healthcare disparities. And even more specific, you are here. You have tuned into this webinar series. So I know that you are on the front lines to end dermatology, health disparities, and inequities. So who needs help? Who is less likely to even get to see a dermatologist? Blacks, Hispanics, men, those on government-supported insurance like Medicaid, Medicare, those without insurance, those who have low income and less education. Primary care physicians and providers, you are on the front lines of seeing dermatology patients, whether you think about it that way or not. 1/4 of all of the visits to your office involve some type of skin, hair, or nail problem. Let's think about atopic dermatitis, one of the most common skin conditions that we all see. Pediatricians, hands down, they're going to see the most kids with atopic dermatitis, not dermatologists. Primary care is going to see more acute atopic dermatitis flares. Dermatologists like me, we're going to see more chronic atopic dermatitis cases. So we have to make sure that you are prepared to be on the front line of dermatology. That means that, we have to look back to see what happens. Why are so many primary care physicians and providers not comfortable taking care of skin or being able to distinguish things on the skin, especially in skin of color? Well, they may not have had dermatology be a required part of their training. There could have been very limited access to dermatology educators, and the patient population that they serve may not be very diverse. So let's dive into some pediatric caveats in darker skin tones. And these are some things that you may see in your office this week. So I want you just to kind of challenge your brain here. This is atopic dermatitis. On the left, we see that atopic dermatitis in a patient with brown skin. We can see erythema in the background. You've been practicing since the last lecture. Hyperpigmented plaques, lichenification or thickening of the skin. And on the right, you see more of a picture that you may more commonly pick up and say, oh yes, that's definitely atopic dermatitis. It's on the right place of the skin. I see the erythema and the thin plaques on the antecubital fossa. So they are both atopic dermatitis. They look different. Here's atopic dermatitis on the lower legs. On the left, definitely hyperpigmented, lichenified. On the left, you just may see some pink thin plaques with some scale. And, that is easily recognized as atopic dermatitis, but so is the atopic dermatitis on the left. So let's think about some more serious conditions like Staphylococcus scalded skin syndrome. So recognizing erythema in this situation can be life-saving. On the right, it is very apparent that the child is having some superficial desquamation, and also the child is very, very red. And on the left, if you look at the child's lateral cheek, you will see that that is the child's normal skin color. And if you allow your eye to move back and forth between the child's cheek and also the trunk, you can definitely begin to see that, yes, there is diffuse erythema of the skin. And tinea capitis is basically a ringworm of the scalp. So on the right side, we would easily diagnose this ring-like structure with raised borders and scaly borders as tinea corporis, or ringworm of the skin. But in Black school-age children, it may present like this, just looking like seborrheic dermatitis or dandruff of the scalp. So it is definitely important to be able to pick up those subtleties in presentation based upon the skin type of your patient. And let's talk about post-inflammatory hypopigmentation. On the left, definitely an example of a newborn, of an infant who had most likely maybe atopic dermatitis or seborrheic dermatitis on the face, which has left behind some post-inflammatory hypopigmentation. So as you're explaining to the patient's parent that this is what they have, their mind may drift off. They may actually be thinking about the implications of their child having a pigmentation disorder. In skin of color, having a pigmentation disorder can be very devastating. For an example, in the family on the left, this is an example of a South Asian family. And so as you are talking about this infant, that family may be thinking about, oh my goodness, is my child ever going to get married? Because in some countries, pigmentation disorders cause people to be shunned and feel like they're outcasts from their own society. So you really have to think about being culturally competent when you're taking care of patients so that you can take care of the whole patient, not just the skin disease, but also the impact of that skin disease and the importance of explaining to your patient what to expect. And finally, we'll talk about hemangiomas. So hemangiomas are the most common vascular tumor in the pediatric population. But think about when we talked about access to care. If you have limited access to health care, your child is going to present with a much larger lesion, and those kids may not cosmetically do as well. So definitely want to get patients in sooner rather than later. And finally, we definitely want to increase educational opportunities for all primary care doctors to learn more about hair, skin, nails, and to really increase the time that is spent learning dermatology. Also, increasing competency is for all of us, even for dermatologists. We need to be better about delivering culturally competent care for people of all skin tones. Increasing the pipeline of physicians and providers who are health disparity elimination advocates is very important. And I definitely don't want to leave out the advocacy groups. So increasing not only health literacy, but also being advocates for economic change around housing, education, and health literacy can actually impact someone's health. So I just wanted to end by saying that all of these proposed solutions really take all of us. And I'm asking you today, will you be an advocate in the quest to eliminate healthcare disparities? And last slide, I just wanted to highlight 2 children who have died from COVID-19. On the right is Skylar Herbert. She was the very first child to die from COVID-19, and she is the child of frontline healthcare workers. And then also on the left, we have Honesty Hodges, who died recently at the age of 14. And her name often sounds familiar because when she was 11, she was actually handcuffed and put into the back of a police car. And it really sent outrage across the country. And it actually led to a change in police policy about how children are handled around handcuffing. So she has also died from COVID-19. So I just wanted to end it with some real people, real pictures, and just really remind you to look out for the signs for COVID-19 in all age groups. Thank you so much.
Dr. Heath, thank you so much. So much great information there. And I know as a pediatric resident, I was very sure of what that scalded skin syndrome looked like from those classic images, but had never really seen anything comparable in skin of color. Thank you for that presentation. And we'll just keep moving forward. Thank you. And thank you for honoring those who've lost their lives to COVID. As we move forward, we have another final presenter, and we are excited to introduce Dr. Jenna Lester. Dr. Lester is a board certified dermatologist working in San Francisco, California. Dr. Lester is an assistant professor of dermatology at UCSF, where she practices and teaches general dermatology and is the founding director of the Skin of Color program within the Department of Dermatology at UC San Francisco. Dr. Lester is a sought after lecturer. We're lucky to have her here. Has written book chapters and published articles in peer-reviewed journals, and is currently building an academic research program in dermatology. Dr. Lester.
Hello, thank you so much for that introduction. I feel very honored to be here today with you, Dr. Manning, and with my co-panelists, Dr. McKinley Grant and Dr. Heath. I'm happy to talk about this incredibly important topic as well. So without further ado, Dr. Heath just gave an excellent presentation on the cutaneous manifestations of COVID in pediatric patients. And I wanted to supplement that with some information on the cutaneous manifestations of COVID-19 in adults. And we have another photo here of COVID toes. I think repetition is the greatest teacher. So we'll be seeing some duplicate images, but it gives you more time to sort of incorporate it, burn it into your brain. But as Dr. McKinley Grant mentioned, erythema is an incredibly important sign to be able to pick up on in the skin. And you can see these acral papules on the dorsal aspects of the toes in these pictures. And it may be more subtle in its appearance in the photograph on the left in the patient with brown skin. You see more of a violaceous to slightly magenta appearance there, abutting the proximal nail fold on the toe there. And it's a little bit more obvious in this patient on the right with white skin who has bright pink to red papules. And in these patients, in patients with COVID toes, we know that disease is more mild. These patients are less likely to be hospitalized as compared to patients with other cutaneous manifestations of COVID-19. And our colleagues in the American Academy of Dermatology who put together a database study on COVID-19 patients found that only about 29% of the patients they studied met 3 or more CDC criteria for PCR testing when they had COVID toes. So this is more of a testament to the fact that this disease is quite mild. And 19% of patients with COVID toes actually have no other symptoms of COVID-19. So seeing this skin finding should prompt a conversation about PCR testing. And this is an example of how looking at the skin can really change one's medical management. It could prompt conversations about sheltering in place and isolating. And on the next slide, we see that we see an example of urticaria. And urticaria are edematous wheals They can look like papules in the superior aspect of this photo and can coalesce into plaques, which you can see in the lower right-hand corner. And they're actually, in both of these photos, they're on a base of erythema, and that erythema is more obvious in the patient on the right with white skin, but is also present in the patient on the left. And you can see sort of at a border of a violaceous to a slightly red appearance. And you have to see this over and over. And then once you see it, you can't unsee it. The findings of the actual urticaria are also more subtle in dark skin as well. You see this patchless expression of the follicular ostia where they're stretched open a little bit. And sometimes it can even be helpful to ask the patient, can you show me where you're having the rash? And then you can clue into those findings. And I highlight this just because it is such a subtle presentation in patients. And the next slide we see are a manifestation of COVID-19 papulosquamous eruption. So that's just the general word for scaly papules and plaques. And an example of that is a pityriasis rosea-like eruption. These are both representative photos. These patients don't have COVID-19. But we see these ovoid to annular erythematous scaly plaques. And on the right, again, in accordance with our theme for today, the erythema is bright red to pink. And on the left, the erythema looks a little bit more violaceous to hyperpigmented. And what's also on display quite beautifully in this photo is a clinical variant in pityriasis rosea where we see a papular eruption, which could be the main hallmark feature of pityriasis rosea in patients of color. And you can just see all those bumps in addition to a few scattered ovoid plaques, whereas on the right, the prominent feature are these ovoid scaly plaques as opposed to papular lesions. So the research that we have right now suggests that most adult patients get cutaneous manifestations either concurrent with their development of other COVID-19 symptoms or slightly after. However, there is a portion of patients who develop cutaneous manifestations in the absence of symptoms or before they develop any symptoms, as I mentioned with COVID toes. So it's quite important for us to be able to identify these as a skin sign of what's going on systemically so that we can teach our patients how to self-identify and can have conversations about testing. And it's important for us to be able to do this in all skin tones. However, on the next slide, we'll see that the majority of depictions in the publication of cutaneous manifestations of COVID-19 have been in white skin. And this was an analysis that I performed with my co-authors looking at doing a systematic literature review of any article that talked about COVID-19 cutaneous manifestations and also included a photo from December 2019 to May 2020. And as you can see, these rashes are almost exclusively depicted in white skin. And this was something that I was noticing, and I felt like this was watching a disparity layer on top of all the other disparities that we know exist with COVID-19. And if a patient has a rash and they're like, well, I heard that there's a rash with COVID, let me go look it up online to see if this matches. If that patient has light skin, they may be able to find something that looks like their rash, and then they schedule an appointment with their doctor and ask, do they need testing? But if a patient has dark skin, they may not find anything that looks like their rash, and it may lead them to delay care. So this was an example of see something, say something. And I wanted the larger medical community to address this, and also just for this to serve as a call for action for all of us to take more photos of all skin disease in patients of color, but particularly COVID-19. And, this was an issue that I became interested in. This is something that has been talked about for a long time. And, some of the giants in our field of skin of colors, this is something they've been calling out for forever. And I really feel like I stand on their shoulders in presenting this information. And on the next slide, we see how this inadequate or imbalance of representation of skin of color in dermatology is really an example of one of the many instances of structural racism that exists within our specialty. And in the chat, you'll see links to to two articles that prove this through counting photos in our common teaching textbooks. And we find that there's overall a minority of these photos are in patients with dark skin. But actually in the chapter on sexually transmitted infections, there is an overrepresentation of skin of color. And that's something that Dr. Manning mentioned in her introduction. And that's something that anecdotally people notice, but this is something that has been proven. And what does this do? What does this structural inequity do? Our learners who are consuming these images, and by learners, I mean residents, I mean medical students, I mean clinicians of all stages who are doing continuing medical education, they consume these images, and that serves as their input. And that input helps them to form cognitive heuristics, or shortcuts that our brain takes when we are interpreting and processing patterns of symptoms and diseases in an effort to make a diagnosis quickly with as much accuracy as possible. And our output is only as good as our input in that situation. If you only ever see skin disease in light skin, that may lead you to be a little bit less accurate when you're diagnosing something in dark skin. If you only ever see sexually transmitted infections in dark skin, that can lead to several powerful anchoring biases that may lead you to lock into salient features of a patient of color who's presenting to your clinic, and may also lead to misdiagnosis, not to mention alienation of your patient. And there was a study that's also linked in the chat that showed that a survey of 47%, a survey of graduating dermatology residents showed that 47% of them did not feel like they had adequate skin of color education. And what that does is that creates a lack of confidence in your own abilities. And you walk into a room with a patient of color and you need to make a diagnosis, and you're unsure because you're thinking about how you didn't learn about this in residency. And that uncertainty is palpable to the patients. Our patients are incredibly smart and they pick up on that. And if you have a patient of color who maybe has already experienced medical trauma, has been disregarded, has felt like they're not heard, and they're giving us as the medical community a second chance by continuing to engage in care, that feeling that their provider doesn't really know their skin is very damaging. So this is an important structural inequity in our education system that we really need to address. And our current paradigm is showing skin disease in light skin over and over and over again. And maybe you get a few photos of dark skin sprinkled in there. But as we can see on the next series of slides, if we're looking at psoriasis in this patient, and you can see there's some mild erythema along the hairline as well as scale. And you see the next slide where you see this inflammation in this patient with brown skin and a plaque-like formation. And then on the next slide, you see a more subtle appearance of psoriasis with more annular plaques, where the erythema is not as obvious and more closely approximates the color of this patient's normal skin. And you see the next slide where this patient has a violaceous or more magenta appearance to their psoriasis. And Dr. Manning mentioned salmon pink plaques with silvery scale. She was referencing Still's disease, but salmon pink patches or plaques, psoriasis. So these pink plaques, and you see the same thing here, are not the way that that it's classically described in the literature. But if you see these over and over, and this is your introduction to psoriasis as a learner, then the next slide, you see psoriasis, and maybe this isn't as recognizable. And typically the reverse is happening, where you see images of psoriasis like this over and over and over again. And then the psoriasis in darker skin is less familiar to you. And what I'm advocating for is an increase in the balance. We need to see it in every skin type. And like I said, repetition is the greatest teacher. So it's important that we see it over and over again, because we can't diagnose what we don't recognize. And similarly, another thing that I hear a lot with my patients, and that I think is as important as adjusting our educational system so that our educational materials so that they represent the patients that we see, is centering the patient's experience in their medical care. this patient, who looked a lot like the photograph on the left, had an axillary rash with inflammation for several months, and she was seeing a doctor who recommended she change her deodorant and gave her topical steroids. And after several weeks of that treatment, she returned to this physician and let this person know that her condition was not improving. And throughout that interaction, she felt like her thoughts were not being heard, and that her experience of her treatment was not being incorporated into subsequent modifications in her treatment. And so much of our interaction was talking about feeling disregarded by the medical system, not feeling heard by providers, and what that does to your confidence in your medical care. And putting on my thinking cap and thinking of the full differential for an axillary rash, especially in the setting of treating something inflammatory that per the patient did not help, I got out my Woods lamp, and on the next slide, we see the classic coral red fluorescence of erythrasma. And erythrasma is a superficial bacterial infection that will not be adequately treated with topical steroids, but requires topical antibiotics, which we started in this patient and she promptly got better. So it's important to center your patient's feelings and experiences. And I think this is true with all patients, but particularly with patients that have been historically excluded from our medical care. And a final example of the importance of repetition is a patient who came to me with bumps on her cheek, and she also brings her prescription for imiquimod, which is a topical immune modulator that we use in treatment of warts, and said, this isn't really helping me for the warts on my face, and I'm also getting a lot of irritation and hyperpigmentation. What else could I do? And so I was happy to give her the diagnosis, which we see on the next slide, is dermatosis papulosa nigra. And this is a very common condition that I see in patients of color, particularly Black and Asian patients. And I was happy to inform her that this is not an infectious condition at all. It's also not something that will be adequately treated with imiquimod. She was happy to know that it was nothing to worry about and was happy to leave them. I have patients that do want them removed, and it's something we can do. But I think it's really important that we adequately counsel our patients and let them know what's going on. And we're unable to do that if we don't know what we're treating, and that goes directly back to our education. So it can be overwhelming to hear all of these issues that we have, but I'm happy to inform you that the solutions are well within your hands. And a very simple thing we could do is we could take photographs of skin disease on all skin tones. You as internal medicine clinicians, primary care providers of all types, are on the front lines of dermatologic care. We know that only about 30% of dermatology concerns are ever seen by a dermatologist, which leaves 60-something% left to be seen by everyone else in the medical community. So this issue is very squarely in your court. You can use those photos and share them with your colleagues. I think Dr. Heath's presentation was an excellent example of how we use photos from colleagues from all over the country to give excellent examples of and teaching examples of cutaneous diseases. You should represent all of these in your lectures. I think journals should require diverse representation of skin types in publications, regardless of the topic of the publication. You should ask yourself, who was helped and who was harmed by this representation of my photo? Am I harming patients of color by only showing syphilis and dark skin in this lecture? Am I doing a disservice in other ways by not showing dark skin and psoriasis? And then I think, a common theme of all of our panelists today is recognizing the importance and impact of patient advocacy. And that can look like a lot of different things. Patient advocacy can look like, saying to your colleague after their lecture, you should have had a little bit more diverse photos in there. I actually have that in my photo library. Let me share them with you. Patient advocacy can look like a see something, say something situation where you're publishing on an inequity that you notice. And it also can be one-on-one in the patient interaction where you are centering your patient's experiences of their treatment and their disease when you are proceeding with their care. That's incredibly important for all patients, but I think is especially important for patients of color and patients who have traditionally experienced disparities as a result of inequities in our medical system. So with that, I would like to encourage you to keep talking to, can you hear me still?
I was just clapping for you.
Oh, okay, because I'm getting all sorts of notifications. I'd like to encourage you to keep taking excellent care of patients, of all patients, and to keep motivating each other to break down these structural inequities and structural barriers as you see them happening. So thank you so much for your attention and your time. And thank you, Dr. Manning, for keeping me on time.
You were amazing. And you all, since I'm a teaching nerd, one thing that I know is that you got to watch the time. And so what we're going to do together is I'm going to challenge our panelists to something really cool. And I want you all to see if you can answer a question in 30 to 60 seconds. And I'm gonna start snapping if you start rolling up on that 60 seconds, because we want to be able to get some of these questions answered. And so one of the first questions that we have right out the gate is about what resources do we have available for pediatric, like a pediatric dermatology atlas and resources for people to look at skin of color in pediatric infants and kids.
The only one that comes to mind right now is called Pediatric Dermatology by one of my mentors, Dr. Nanette Silverberg, and Dr. Tay as well, and Dr. Duran. So there are some authors from around the world, and I do have co-authored some chapters in that textbook. So there is one.
Awesome, thank you. And if someone can drop that into the chat, that would be fantastic. Not you, Dr. Heath, because I want you to listen for these questions with us. Our next question is about how can patients and healthcare providers be advocates in addressing health disparities? I am going to start that one to Dr. Lester.
I think this doesn't have to happen in as big of ways as people think, and that I think creates anxiety about how you're going to go about doing this. I think it starts in your own circle. So like I said, gently and kindly telling a colleague, you know, I think you could have done a better job adequately representing all different skin tones in that lecture that you gave. And you know, asking for feedback from trainees. Do you feel like you're learning about this condition in all the patients that we see? So I think advocacy starts with yourself and just small adjustments that you make to your teaching.
Thank you. And Dr. McKinley Grant, I want to ask you this question. With COVID patients being so sick, you know, gasping for air, in the ICU, there's so much to stand in the way of us calling a dermatology consult. Why should we take the time to call dermatology when somebody can't breathe? And what would be the advantage for us to do this in these high acuity situations?
Yeah, so we have this usually with the COVID patients, the ICU will call dermatology because they don't know what's going on. It might be a herpes rash or whatever. And we found the residents go in, they try to, you know, they want to get an image so they can send it back to the attending, so that blah, blah, blah. It takes two people. They have so many people working who are sick already, you know, that it's really hard, really hard. But I think it's just a matter of, like you said, skin is in your face. So if you happen to see something, then, you know, see what help you can get. You can describe it to the dermatologist. Maybe they won't have to come there, or you could recognize it yourself. You know, something as simple as herpes can just be cultured. And it's really hard, but and if the patient's complaining of something, or unexplained fever, you know, you want to look for herpes, just common things. You don't always need the dermatologist, but see how you can use the skin to help you further with your diagnosis.
You know what, Dr. McKinley Grant, that makes me think of something else you taught me as we prepared for this session. And that was about how as our patients get brought into care, especially as we think about disparities and people who do not have access to care, those who are very sick, who are now in your care, if you see something on the skin and you don't know what it is, perhaps this could be that moment where they get something that's biopsy that has nothing to do with COVID, but that could save their life. And so those things that you aren't so sure about, don't hesitate to call our dermatology colleagues. Let's move on with another really great question. And this one is, should COVID patients who have skin findings, but absence of other symptoms, be isolated for a longer period of time? I want to know that answer. Who wants to help me with that one?
I think they need to be isolated for a longer period of time, but I think they should perhaps get tested and should isolate according to the CDC recommendations, which I believe are changing today. But from 14 days to, I heard 7 to 10 days. But I don't necessarily think they need to be isolated for longer. But as I mentioned, a lot of these findings happen in the absence of other symptoms and could indicate that someone has a COVID-19 infection.
And the beauty of our multidisciplinary panel that we have here with Dr. Rubin from Infectious Diseases has chimed in low key in the chat to say he believes that there is no additional isolation that is needed there. So following those CDC guidelines. Okay, I'm gonna try one more for the road because we're low on time. Let's see, can each panelist quickly give their favorite atlas and their favorite derm textbook for learning about skin of color images and more broadly derm images. And before you say that, let me say this. You all, VisualDx is available to you for all of these images. And as we throw that speed breaker down and think more about skin and skin of color, going that extra mile, it is so easy just to get the VisualDx app and have this thousands and thousands of images at your fingertips. So you guys, everybody's going to get visual diagnosis, but in addition to that, what say you? Dr. McKinley Grant, you first.
I would say the Kelly textbook is great to have. And I was going to say VisualDx, but you added that already. But
they all are going to get that after today.
Yeah, I know.
Okay, Dr. Heath.
I would have to agree with Dr. McKinley Grant. Dr. Taylor is my mentor, and years ago when I was her clinical research fellow, she would wake up 2, 3, 4 in the morning to edit this textbook that was going to be, this amazing thing. And it is. So just because I was, watching in the trenches, it really holds a special place in my heart. Paul Kelly and Susan Taylor's Dermatology for Skin of Color. And it's actually won some literary awards as well because it reads so well because she pored over those pages.
Fantastic. And Dr. Lester, what say you?
Well, I agree with that. Dr. Taylor is also one of my mentors, and spending a ton of time in her office, seeing her. I was there when she came out with the second edition. I also saw Dr. Heath's photo with her in her office. That's how I first got to know who Dr. Heath was. But there's a dermatology atlas for skin of color that's very heavy on photos. So that is helpful for flipping through. There's a lot of pediatric cases in there as well. So I would say that would be my other recommendation. And that's by Dr. Amit Pandya and some other authors whose names I'm forgetting. I apologize.
There's one other one also by Dr. Bilcha and Dr. Scott Norton called African Dermatology. And I'm not sure it's in print, but absolutely amazing images of more, tropical derm, which we're seeing more in the United States too.
Well, fantastic. And I just want to say, I can't say enough, thank you to our amazing presenters. Also, huge thank you to our sponsors, to also NEJM, which also is a great resource to you for their collection of articles and interviews on skin of color, and of course, VisualDx. Just want to say thank you to Dr. Lynn McKinley Grant, Dr. Candace Heath, and Dr. Jenna Lester, who you can find on Twitter. So follow them. And as we wrap up the series, I'd just like to welcome Dr. Simo Desai from the Skin of Color Society to share some final thoughts. Dr. Desai.
Well, thank you very much, Dr. Manning, for your excellent efforts in moderating today. It's been a pleasure to have you join. And thank you to all of our panelists for the fabulous lectures and these sessions, which have really put together an amazing journey in skin of color, health disparities, and inequalities in medicine. All 4 of the sessions that have been presented over the past few weeks have provided such thought-provoking content and actionable takeaways for all of us. And as the immediate past president of the Skin of Color Society and a board-certified dermatologist, it's really an honor to have been a part of the planning and execution of these. I'd like to give a special thanks to Leslie Kumler at VisualDx for all of her fantastic work in putting together the behind the scenes graphic design. And I would be remiss without thanking Kathy Belisle at the New England Journal of Medicine Group and Kim Montanarello at VisualDx for their incredible and tireless efforts in collaborating with all of our organizations and our speakers throughout these phenomenal events. All of the staff at the Skin of Color Society, at the New England Journal of Medicine Group, and VisualDx have really dedicated their heart and souls to making this happen on such a global stage. And most importantly, thank you to all of you in the audience who have joined in week after week, literally tens of thousands of physicians and colleagues, residents and students from around the world. This has really been a dream for many of us that has come through to fruition. And this journey doesn't stop now. We are looking for the next phase of our actionable goals and ways that we can partner together with you in the healthcare community, with our organizations and beyond. So please fill out the survey that will be available after the session today. All of the educational links and recorded lectures from all of the 4 webinars will also be posted to the websites at skinofcolorsociety.org, at New England Journals of Medicine Group.org, and VisualDx. This is just the beginning of the conversation, and we are hoping to build a community and one that is purposeful in its approach to improving care for all of our skin of color patients, not just in dermatology, but in all of medicine. As you leave here today, we hope that you feel educated, empowered, and enlightened, and we hope to have the opportunity to do more of these interactive discussions very soon. And until we meet again, thank you for being part of the conversation. Stay healthy and stay well.